Very good morning to everyone here. So, at the outset, I want to today I'll be talking about optical strategies for myopia progression. But having said that, optical strategies have been around for ages, and we've been prescribing glasses as a first and basic step towards myopia control or myopia, let's say, control. But in a country like ours, where reading and academics is given so much of importance, and we live in places which are crowded, and we have very less access to direct and far looking outdoors. And also, when working environments have become much and much closer, and children have easy access, even in rural areas, to mobile phones and such screen time, it becomes imperative for us in India to step up to this particular condition. May I know, anyone can search, what is this? There is a story behind this. Can anyone just guess? Exactly. So this is the London pump for cholera. So when cholera was a huge epidemic, people were wondering where is it coming from, and it was all originating from this single water pump from London. And today we can say that just like how the London water pump was a source of cholera, the schools are now become our London water pumps, because all our schools have now become these huge funneling areas for, like, increased near work and more of academic stress. So at this point, we need to stop and look back at our policies and stringent academic policies, and kind of rework on that. When we did a small screening program in Chennai with 25,000 kids, we found that refractive errors formed around 27% of the screening program, and myopia was almost 16.7%. But this is again something that we don't do with cycloplegic refraction. This was a screening program. I'm pretty sure that the more and more we do, the numbers are going to start increasing. And these are all numbers that used to be around 5 or 6% probably a decade ago. And why is this important? Because pretty soon we are going to be seeing fundus like this in the future, and we are going to have more and more kids who are going to have other issues in the future as well. So this is a very impelling picture from Professor Jonas. This is a single patient who's been followed up for over 2 decades, and you can see how the myopia maculopathy has progressed and how the vision loss occurs over a period of time. And this is the reason why we need to do myopia control. And one more important thing is that we all fall back on refractive error. But as Dr. Shivaraja was also mentioning, axial length and corneal ratio, the axial length as such is a much better predictor of myopic maculopathy. In fact, so much that any axial length that is more than 26 mm. Can I have a pointer, please? Do you have a pointer? Okay, I think the mouse works. Yeah. So more than 26 mm, and the risk just jumps to 25%. Now, what do we need to manage myopia in India? We need to have some customized programs that has to be easy to use and that is accessible and also cost effective. Now, how can a simple pair of spectacles solve this problem for us? Well, let's see. It all starts with the first step when you see the patient and giving them an optimal correction. A child who wears a full cycloplegic correction that is confirmed by a duochrome test, thank you, is actually the best thing that you can do for a patient at the first visit. So we do not jump to optical corrections and optical interventions like control strategies in the first visit. Ideally, we would like to wait, because we do know that almost all, including atom studies, say that 20% of the kids do not necessarily progress. So we can wait and watch. And for when should I start dispensing? This is the 2022 APOS guidelines for those who have want to know when to start dispensing. And also this is the Indian consensus statement from AIMS. And again, here you can see more than 3 diopters beyond 2 or 3 years. And then anything beyond, less than 2 years, and anything as per refraction beyond 2 to 3 years is what we recommend to start dispensing glasses. Now, another common misconception that we have is undercorrection. Now, I want to just put this forward here. Why do people undercorrect? And studies propose that almost 16 to 17% of ophthalmologists generally like to undercorrect. And why is that? Because here you see this is myopia. The image falls in front of the retina. When you give a correction such as a lens, and what happens is it falls, you bring it back onto the retina. And what happens when you undercorrect? When you undercorrect, you bring the lens, you bring the image between this in a form of a blur circle. And this undercorrection was the reason behind this is because it probably brings the image in front of the retina to present a retarding blur stimulus, and this reduces the accommodative stimulus to the patient and the demand at near, and thus it reduces the blur that drives the accommodation. And those earlier theories were that arrested accommodation prevents myopia progression, and that was the reason why people used to undercorrect. But surprise, surprise, we realize in multiple studies now that undercorrection really does not work. So why does it not work? The main reason is that now we have evidence, compelling evidence, that fovea is not the driving force for axial elongation. It is the peripheral retina. It's the mid-peripheral retina, in fact, that has the primary role to play in myopia progression. The second is the retinal defocus. Once the child has myopia, any form of undercorrection or all of these defocus systems may not be actually working in the center of the fovea. It's only the mid-periphery. And that is why optimal correction in the center is extremely essential, and correcting the peripheral retinal defocus is the most effective form of myopia control. Now, dispensing glasses for myopia, just a few slides on this, because we tend to have, high myopes tend to have issues like these. They have these kind of prismatic defects in the periphery. You can see these minification of image and the kind of lens thickness that you see, this kind of lens, increased lens thickness. So choose your right IOL using a recommended refractive index. So obviously we do know that increasing the refractive index brings about a much better visual clarity for the child. So this is the recommended table that we follow. So a child who has about minus 2.25 would be around 1.59. And if it keeps increasing, the sphere keeps increasing to higher myopes. Ideally, up to -5 would be 1.61, -8 would be 1.67, and anything more than that would be a 1.74 index. And this is how we recommend going for the lenses. It's also interesting to note that children who have cylinders in the 90-degree axis would have thicker lenses than they would in a 180-degree axis. And this is something we need to counsel the patient also. So this is a same power, but in two different frames. So it's not just the lens, but also the frame that really matters. The same power, but put in different frames may actually have different, may have a much thicker, like much thicker view. So it's always important to have smaller A and B size. Do not have square borders because that will enhance the reflex that comes. Not recommended to go for metal or rimless, and preferably not flexible frames in high myopia because they pop out easily. And increase the IPD to kind of provide that kind of reduce the peripheral thickness and remove it, and go for darker colors and reduce the vertex distance as much as possible so that the child wears it close to face. And for every 1 degree of pantoscopic tilt, it's always recommended to lower the optical center by 0.5 mm. So these are the recommendations. Now we move on to what we call a special, the so-called special lenses and how they work. Now, once these optical strategies were in place, now we've moved on to certain things called not just myopia correction, but myopia control. Myopia correction is just correcting and providing clarity, whereas control is actually providing a effect of stopping the progression or minimizing progression. Now, this is a huge list of lenses that have been under study. So it's not a recent thing that's been there. It's been around since 1960s when the accommodation theory was put into force, where they saw that, excessive accommodation causes myopia progression. And based on that, the progressive addition lens came into play. And there are many types of these that were initially under study, where simply adding a plus lens kind of reduces the accommodation, thereby reducing the myopia progression. But we've grown from there, and now we know that the peripheral defocus theory is what is currently we do believe in, and we have these multiple segment lenses, as you can see in this. This is the DIMS, the Stellest, and the Myocare. And these lenses now incorporate the concept of multiple segment to negate the peripheral defocus. And of course, the newer concepts that have come in now, that's the contrast theory. And this is the dot lenses that have now come in that talk about low and high contrast and how it affects myopia progression. Yeah, so that's about it. Now let's just look at the accommodation theory. So when a child does a near work, for example, is reading a book, then you see that the visual image is actually focused on the retina. But however, when the child is constantly doing far and near work, or when the child is having a weaker accommodation, it creates the accommodation is not strong enough. It creates a hyperopic defocus. And this was the earlier theory, that it kind of creates a stimulus for the eye to keep growing back. And that is the reason why the progressive accommodative additive lenses came into play as a type of myopia control lenses. However, that is now crossed, and now we have come over to the peripheral defocus concept, wherein the center, the fovea, is important for central vision. What happens in the mid periphery is where the issue is going on. Here, what we see is that in myopic children, because of the way the posterior pole is shaped, the children who have good central correction tend to have rays that are they fall behind the retina, creating a peripheral hyperopic defocus when they are corrected with a simple concave lens. So in those cases, what happens? The hyperopic defocus creates a stimulus for further growth, and the eye thinks, it tricks the eye into thinking that you've not yet reached emmetropization, so continue to keep growing. And what happens in these peripheral defocus lenses are that these lenses actually kind of bring these rays a little forward. They create a plus power here, they add a plus power here, so they bring the rays a little forward, creating a myopic defocus, thereby telling the retina around this area that, listen, it's time to stop growing, and it's done, you can stop growing. So this is the kind of signaling that we are trying to alter in these glasses. So this is the defocus, the DIMS lenses, or the defocus incorporated multiple segments. This is by Hoya Myosmart, and you can see that they have a central 9 mm clear zone, and these are followed by small lenslets, each of which are plus 3.5, and this is a fixed 3.5 diopters. Each is almost 1.03 mm in diameter, and they're kind of placed close to each other in a hexagon shape, and this controls the peripheral rays. Now, there was a study that looked at how is the vision through these lenslets if the child looks tangentially, and they did notice a drop of 1 or 1.5 lines, but really it didn't matter much, because most of the time the child is looking through the center, and the peripheral vision drop doesn't actually bother much of the vision. Now, the DIMS lenses have a 6-year data that's been published, and they have the sad part of these are usually the longer the study is, the numbers kind of fall. And here we had about 36 kids who completed the study at the end of 5 years in group 1, which is only DIMS spectacles. Group 2 were 14 kids who completed it. The group 2 had DIMS lens for the first 3.5 years and then were shifted to single vision. And group 3 were 22 kids who were single vision in the first 2 years and then were switched to DIMS. And what was found that throughout they kind of had 0.9 diopters of correction in the 6 years, and with corresponding axial length correction, which is good. So almost 1 diopter of prevention. Then comes the SLR Stellest, or the Hall technology. Again, a very similar kind of a science behind it. The only thing is that they talk about volume of defocus. Now here, when we look at DIMS, the DIMS lenses had about plus 3.5, which is fixed, but the Stellest have a proprietary reduction, the increase in the power as it goes from center towards periphery. So what you see maybe 3.5 to start with, but towards the periphery maybe around plus 5 or plus 6, and we still don't know how the increments are. But what it does is it pulls back the focus more towards the periphery than at the center. So you can imagine this kind of a volume of defocus that it creates rather than a fixed plane of defocus. So thereby they say that Stellest works in a much more effective manner. And this was a 6-year study that, again, a 5-year study that is recently published at RO 2024. And they say that Stellest slows myopia progression by 1.95 diopters and axial length by 0.81. And this is the latest that is being presented at the RO conference. And here you can see 2 diopters in 5 years is quite a significant control again. But again, the problem is with numbers here, and we're looking at somewhere around 40 kids, and that's again a very small number to kind of generalize our results. So we need to do more studies on this. Then comes the Zeiss MyoCare. Again, MyoCare in Asian children after 12 months of where they found a 0.31, which is not as great as the Stellest and the Myosmart. But here again, you can see these are the rings that are formed, and these are annular segments, again with powers that kind of increase. And they have tested it both in Asian as well as in Caucasian children, with a modest effect in Caucasian children compared to Asian children. So now we come to the newer one, which is the contrast theory. The contrast theory is something very simple. So this is something from a natural scene. A normal natural exposure to your eyes would probably result in an image like this. But when you look at a screen, the same image on a screen, it's highly improved on contrast. So you can see that these images have much clearer contrast on screens rather than a natural thing which has a lot of sunlight to kind of defer off your contrast sensitivity. And that's what they say, that when a child is emmetropizing, they always look, the cues are off contrast. So as the contrast becomes lower and lower, the eye it's a signal for the eye to stop growing. The higher the contrast, it means that the object is closer to them and the eye has to continue to grow. So that's the concept of contrast theory. So it is based on the bipolar cells, okay? And these bipolar cells are very important because they send the midget bipolar cells send signals to the amacrine cells to release dopamine. Now there are different kinds of bipolar cells, the on and the off. Now when both center and they're in a particular fashion arranged such as center and surround. When both the center and the surround cones are covered by equal illumination, there is no contrast. It's zero contrast. However, when the center cone is more stimulated than the surrounding cones, then the on bipolar cell is stimulated. And when the on bipolar cell is stimulated, there's more dopamine that's secreted. And the reverse is for off. The surround ones are stimulated more than the center. When the high contrast signals start, then the high contrast signals stimulate more of the off rather than the on. And this creates a stimulus for more growth and less dopamine. And this is how they say the contrast theory works. And that's how the new lenses, which are the dot lenses, came about, where they have a central 5 mm aperture, which is the clear zone. And this is followed by full high scattering dots that are there in the periphery, which tend to reduce the contrast sensitivity of the peripheral rays. Now, these scatter dots are about 0.14 diameter and about 0.02 mm in height. And these are really small dots that you can see that you will be able to see them through the glasses. They are not available in India yet, but they are soon to be released by Essilor. Now, we did a small study on DIMS and about 40 kids over 2 years versus single vision. And I'm quickly sharing the results. You can see that there was a pretty good control. We about minus 1.19 in the sync control versus minus 0.4 diopters in the DIMS group at the end of 2 years. And this was statistically significant. And the axial length change was also 0.49 versus 0.17 in the DIMS groups, which was again statistically significant. What was interesting is we saw that at the end of 2 years, 17.5% of kids in the eyes actually did not have progression, or less than 0.5 diopters of progression actually were about 75% of kids. So it actually reduces and brings them and pulls them back into the lower progression zones, so which is very good. And to whom can we dispense these? So we usually dispense these glasses to children who have more than 0.5 diopters of change in progression on cycloplegic autorefraction or retinoscopy, and about change in axial length of more than 0.1 mm a year. Now, having said that, we may have a lot of questions on this. Can we give it at the first diagnosis? I usually don't recommend it. You look and wait for progression, because 20% of the kids need not necessarily progress. Wait for 6 months, look for the 0.5 diopter progression, then start it. What should I measure? Ideally, the axial length and the corneal curvature, as Dr. Shivaraja mentioned, before you start them. How long should the glasses go? Ideally, we keep them on for some time, at least for 2 years, before the patient kind of grows out and they go into the 15, 16s when they decide to go back to single vision, or some kids just prefer to continue it till they're 18. How do I look for rebound? Again, this is an interesting article which said that there is very less rebound in glasses compared to atropine. So rebound is not something that I would be too worried about in glasses. Should I change lenses if there's a 0.25 to 0.5 at 6 months? This is a common scenario that most of us see. Again, I wouldn't recommend it because it takes 1 year for the actual effects of DIMS lenses to start working. So we kind of wait until 2 years to see whether they're really working or not. So I wouldn't change glasses for such a small change. Till what age can we consider them? Up to 18 and sometimes even beyond. Can we use them in pre-myopia? Yes, again, very interesting studies that talk about usage of these lenses in pre-myopia, and they actually work pretty well. So can we combine treatments? Dr. Jetani will be covering that beautifully. So yes, they work very well because as a synergistic effect with atropine. And there are, again, several studies which he will be definitely discussing. The don'ts for myopia control, which I particularly say, is more than minus 12, which is a combination of sphere and cylinder, because that's what's available and it doesn't go for high cylinders. Not in strabismus for obvious reasons, not in unilateral progressions because then you would prefer atropine, and no, not much in high cylinders, and of course other forms of myopia which are not axial. Again, fitting tips, ideal a frame for a myopia control lens would be round. It should be covering your orbital margins completely with an accurate IPT measurement, and the lens should always be close to the face, and that's extremely important. So this is my last slide. The pros are always it's non-invasive, and that is the biggest advantage that we have. They are comfortable, they give good compliance, and they can be used in pre-myopes. And of course, they are known for high refractive errors, and the refractive index is quite, it's a single one, so it's a little thicker for the higher powers. It's only binocular, and of course, cost is prohibitive in some cases. So this is my last slide. Ideally, this is what we would like our children to be like, carefree and moving. We need to move our life outdoors rather than just bring outdoors to indoors. So this is what I would leave you with. Thank you so much.